Okay, hello and welcome to BASWA's Digital Summit. In case you didn't know, this marks the second of 3 webinars BASWA will be running across today. In this context, this webinar series marks the launch of BASWA's new Continuing Professional Development Programme from this October 2019, which has been developed following wider consultation with social workers. It also represents the second webinar organised by the British Association of Social Workers Special Interest Group in alcohol and other drugs. And if you're interested, we will have a third coming up later in the year or the beginning of the new year with regards to emerging trends in drugs. So my name is Wolf Livingston and I'm chair of the Special Interest Group, and I combine social work practice education with that of research about alcohol and in particular the current preoccupation with pricing for alcohol. You can find out more about the special interest group activities and other sort of resources via the BASWA website. So this particular webinar is going to look at the impact of alcohol and other drugs between conception and the age of 2 on young children. It has come about through the work that the Special Interest Group has been doing in developing pocket guides, and we've developed a specific pocket guide called The First 1000 Days, and my colleagues will say a little bit more about that in the webinar. For this webinar, I'm delighted to be joined by Roisin Reynolds and Allison Hulmes. Roisin has worked in the drug and alcohol field since the early 90s, in both clinical and managerial roles, and her current role as Senior Advisor for Alcohol-Exposed Pregnancies at the Greater Manchester Health and Social Care Partnership is to lead on an initial 2-year proof of concept programme to reduce alcohol-exposed pregnancies and progress towards an ambition of ending new cases of fetal alcohol syndrome disorder. During this time, she has worked as a reviewer for the Healthcare Commission and has delivered the Royal College General Practitioners Part 1 and 2, working with drug use in primary care in venues across the Northwest. Allison is currently British Association of Social Workers Cymru National Director and critically the lead author on the new aforementioned 1000 Days Pocket Guide. Allison has substantial experience of working with families and alcohol and other drugs, and particularly in the context of the Welsh Integrated Family Support Services. The webinar will commence and follow a joint presentation from Allison and Roisin, and this will be integrated with a discussion and question session, and the general plan for the webinar is for this to be as interactive as we can make it. We encourage you to use the chat drop-down box on your screen through the webinar and send us comments live while folk are talking as they come to you through the presentation, and then we will try and answer as many of these as we can at one moment in the middle of the presentation and then towards the end of the presentation. Please specify if you would like a particular member of the panel to answer that question this evening, and it would be great to hear from as many of you as possible. Following the end of the webinar, we will provide further communication which will include the recording of this webinar, the accompanying resources, the PowerPoint presentation, and links to the Special Interest Group's web pages, pocket guides, and other resources. For BASWA members, you'll be able to download your CPD certificate in your member area up to 48 hours post the event. And for non-members, if you email us, you can have a copy sent to you. You will also find there's a useful hands-out drop-down, and you can use these to have sent to you the post-event within 48 hours for future reference. So I think that's all from me to set it up. So let's begin, and we'll start with Allison.
Okay, thank you, Wolf. Hello, everyone. I'm going to start my presentation this evening with a brief overview of some of the reasons that the first 1000 days in a child's life is so important. Once I finish the introduction, I'll then be handing over to Roisin, and Roisin is going to deliver her presentation on the impact of alcohol on pregnancy. So why the first 1000 days, which is also known as the golden 1000 days? So it's important that we know what this time frame is. So the first 1000 days relates to the approximate time between conception and a child's second birthday. And it's the period where we see the most rapid phase of brain growth and development, and it sets the foundation for the physical, social and emotional development throughout a child's life. It's a really important critical window for essential learning, particularly in relation to seeing, talking, walking and thinking. I think it's also really important, and a key message is we're understanding more from science and research that the brain is really capable of modifying change and adaptation through the life course, and this is called brain plasticity. And this is really important to remember because, you know, if opportunities are missed during that golden first 1,000 days, there are opportunities that exist moving forward to lessen any deficits in care that have occurred during this time. Although we can't, you know, overstress how important it is that we do take a preventative approach, it's really important that we protect that really delicate brain right from the start. So key message is the care given to a child during the first 1,000 days plays a really significant role in their future health and development. It also reduces the impact and prevent some of the adverse childhood experiences which can occur at that time and which can impact right throughout a life course. So parental alcohol and substance misuse can also impact following a child's birth through a lack of appropriate care, lack of appropriate stimulation, supervision and safety, a lack of emotional availability from either parents or a primary caregiver. And this is a really important time for a child's attachment. So emotional availability of parents and appropriate stimulation is really significant at this time. So some of the external factors which also affect a child's health and well-being during these really important golden 1,000 days are poor nutrition. So poor nutrition can happen when the child is in utero, can also happen after the child is after the child is born. The impact of smoking. We know so much now about the effects of smoking in utero, but also it's really important to ensure that smoking doesn't impact on children after they're born and up to those really important toddler years. Poor parental mental health, domestic abuse, and also poverty and poor living conditions. And poverty and poor living conditions really are causally related to the other factors that I've outlined. So I'm just going to hand you over to Roisin.
Thank you. Thank you very much, Allison. Okay. So I'm going to talk to you very briefly about our programme in Greater Manchester and also very briefly around FASD. Can I say in relation to FASD, you could spend days talking about the syndrome as a whole, but there is lots of information available on both the Dry-Mester website and the NoFast website, which you will be given the links for, so please definitely use those. So primarily our main ambition is to ensure that all midwives are aware of the Chief Medical Officer's guidance from 2016, which is very clear that any alcohol use during pregnancy has an impact, and therefore to keep the risks to your baby to a minimum, you should not drink alcohol at all. At the beginning of September, the Institute of Alcohol Studies actually published a research looking at midwives' knowledge around the Chief Medical Officer's advice across England, Wales and Scotland. And they found that 42% of midwives didn't know the up-to-date guidance and were therefore given inaccurate information to pregnant women. Again, the link to this will be made available as part of the resources that you will get today. So please have a read of that. So in relation to our campaign, we actually went out to one of our communities to ask about knowledge of alcohol and pregnancy.
I assume that you aren't to drink any. I didn't drink at all with either of my pregnancies, but I do know people that did. But then it was only 1 or 2 units a week, if that really.
I'm not sure how much you have to drink. I'm not 100% certain.
My mum just used to say, like, you could have half a Guinness.
No, I'm not sure.
about 2 units of alcohol a week, 2 glasses of wine.
How long was your last drink?
Not sure really, maybe 1 a week. Maybe 2, but I'm not sure of the official recommendation.
I'm not too sure. I know it's not a lot. I would say no.
So as you can actually see from that, there's quite a variety of knowledge around in relation to how much alcohol you can use in pregnancy. And often pregnant women are getting their advice from their mums, from their next door neighbours, from their aunties. So there can be quite a lot of mixed messages around in relation to alcohol use. So a study done, which was published in The Lancet in 2017, showed that the UK was the 4th highest country in the world in relation to alcohol use in pregnancy. 41% of pregnant women admitted that they drank alcohol while pregnant. Now, some of these women will be women who weren't aware that they were pregnant at the time. 4 out of 10 pregnancies in the UK are unplanned. In some areas of Greater Manchester, that's actually 5 out of 10. And the study doesn't distinguish for those women, but it does give us an important fact around how acceptable alcohol is during pregnancy. What we absolutely acknowledge as part of our programme is, and that isn't always easy to stop using alcohol, and it's very important to ensure that women, their partners and their friends and family are aware of what support is available for women who are either considering getting pregnant or are pregnant and alcohol is an issue for them. And again, if you look on the Dry-Mester website, you'll see a lot of the variations of support that we're offering and putting in place for women who are pregnant and thinking about getting pregnant. So in relation to our 10-week campaign, it was a digital campaign and we had 4.5 million content views over that period of time, with just less than 500,000 people engaging, which is a very, very phenomenal number. We were really pleased with that. The most engaged age group were 25 to 34, and the most used platform to view the content was the mobile. Actually, 97% of people viewed our digital assets on mobile. The most engaged socioeconomic group were the D2E group, which is often a group that are difficult to engage in prevention campaigns. So we're really pleased that it was taken on board within that socioeconomic group. The gender split was 80% to 80% female to 20% male. Again, we were really pleased with the number of males that had engaged with our digital campaign, because it's very important for us to acknowledge that pregnancies is not just about women. There's an expectation that actually partners, friends and family do get involved to support the pregnancy. So our challenges in relation to our campaign really was that you need to have open and honest conversations with women with regards to their alcohol use. We have trained 100% of our midwives across our test site to ensure that they have skills in relation to having those difficult conversations and they're able to give appropriate information to women who are pregnant. The number of unplanned pregnancies, and therefore women concerned that potentially they have been drinking a lot prior to finding out they were pregnant. What we're very clear about is this is about no blame, and what you didn't know you can't really control. And it's about the changes that people can make now to ensure that there isn't any damage going forward. There needs to be multi-agency collaboration in this. It is not just about midwifery. It is about all of the other agencies outside of the midwifery that would be involved in working with women who are pregnant. It's very, very important for early identification to actually try and encourage women who are planning to get pregnant to think about plans in relation to alcohol. Support from carers and families are very, very important. We do need to educate carers and we do need to educate professionals, and we have a very, very large training program as part of our campaign. And it's very clear that there needs to be long-term appropriate support for children who have been either affected with fetal alcohol spectrum disorder or have fetal alcohol syndrome. So I'm going to talk very, very briefly in relation to FASD. This is a very, very brief overview. And again, like I said earlier, please look at the websites for the additional information that you'd need. Well, primarily alcohol in the uterus. Alcohol crosses the placenta and enters fetus via blood circulation. So for 1 unit of alcohol for every adult, you'd lose 1 unit of alcohol in an hour, but for a fetus, that can be up to 2 hours. The alcohol is absorbed by the fetus tissue, and actually signs of alcohol consumption can be detectable in the newborn's first fetus after birth. Periods of fetal development. The baby will develop right throughout the 9-month period. So therefore it's important not to use alcohol at all during that 9 months, because depending on when you use the alcohol will therefore depend on what part of the baby's may be affected either by their brain or by their from physical health issues associated with that. So alcohol exposure in pregnancy stages. If you exposed in the first trimester, it's migration and organizations of the brain cells that will be affected and formation of the central nervous system. Obviously, also within the first trimester is the risk of, the higher risk of miscarriage because of alcohol use. During the second trimester, alcohol seems to cause more clinical features, and this may well be when the children are born with the physical features that we will look at in a couple of minutes. In the third trimester, it will be children who have problems with understanding, with reading, with maths, or they have an inability to form or retain new memories. This is an example of what part of the child's development would be affected throughout the 9-month period. I'm not going to go through this in detail. It certainly is worth looking at after the webinar, just to kind of have a look at actually what can be affected during this period of time because of using alcohol. So prenatal alcohol exposure can generally cause no effect. There are some women who will drink during pregnancy and the baby won't be affected. Or they may well have fetal alcohol. There may be fetal alcohol effects. They may be born with fetal alcohol syndrome, or it may result in death. From fetal alcohol effects, it may have alcohol-related birth defects, and they tend to be physical birth defects, or may have alcohol-related neurodevelopment disorders. This is why the message is very much around no alcohol, no risk, because we don't know why some women will give birth to a baby that has been affected, and we also don't know why it will affect some women who drink smaller amounts compared to some women who drink larger amounts. One of the things that we're very clear about is that nobody's asking how much cocaine is safe to use during pregnancy, but we're regularly asked the question about how much alcohol is safe to use during pregnancy. It's also important to think about post-baby and around alcohol in breast milk and the risks associated with that and the impact that may have on the baby and its development, and also the risks of accidental suffocation. We've obviously included this in our campaign, even though our campaign is a prevention campaign. It's really important to have those conversations with mums when you're discussing this with them. So fetal alcohol spectrum disorder consists of 4 different areas. There's fetal alcohol syndrome, which is a child with facial features. Only 10% of children are born with facial features. Partial fetal alcohol syndrome would be a child who's born with some facial features. Alcohol-related birth defects would be a child who hasn't been born with any facial features. And alcohol and neurodevelopment disorder will be a child who's been born and it's cognitively been affected by alcohol pre-birth. There's a variety of symptoms there that you can have a look at, but overall there are over 400 symptoms in fetal alcohol spectrum disorder. And children can be hyperactive, they can have an inability to manage money, they have a lack of control over their emotions. One of the major things though is these children often have difficulties learning from consequences. So if you think about a child in school who is perceived to be naughty, is given a punishment by the teacher, actually then goes on and repeats the behavior regularly, actually the child is disengaging from school as a result of that, and is being seen as a difficult child, or there are behavioural issues, when actually the child can't learn from consequences and needs to be taught in a very different way. Fetal alcohol syndrome will affect in the face several different things. So a child may be born with a small head. They may have undeveloped upper ears, which are often called railroad track ears. They will have a low nasal bridge. Sorry, excuse me, I can't speak today. An upturned nose, a flat mid-face, an underdeveloped jaw, or a very thin upper lip. There will be a smooth ridge between their upper lip and nose, skin folds on their upper eyelid, and they will have small, wide-set eyes. So a child presenting with all of those would be a severe case of fetal alcohol syndrome. So I'm just going to show you a couple of pictures of what that would look like. So that will give you an understanding of what a child with FAS has. But again, I want to reiterate that only 10% of children are born with facial features. In relation to assessing for FASD, actually all countries assess exactly for the same thing. They will all look at the face. They will all look at growth in relation to the child's physical size and their head circumference. They will all do cognitive testing in relation to the brain. And they will all want to know that there has definitely been alcohol in vitro. Now, this can often be difficult because sometimes the questions are not asked. Sometimes the questions are asked and the answers aren't written down. Sometimes the notes don't follow each other. Or if it's a situation where maybe a child is potentially being removed for either fostering or adoption, the parents might feel unable to be honest about the answer. But you cannot get a diagnosis of FASD unless there is evidence that there was alcohol use prior to birth. So different countries will use different methods and different tools to assess, but they will all assess these four things. The main issue around the brain is in relation to a child's executive functioning, which is the frontal lobe of the brain. So if a child isn't born with facial features, it's often kind of 2.5 before you might start picking up some behavioural issues. And initially they can be considered as the terrible twos, but unfortunately they just don't grow out of the terrible twos the way a 3 to 4-year-old generally is expected to. So the red line in this graph will show you a child who hasn't got FASD and what the normal expectation around their executive functioning would be. The blue line is a child with FASD. And as you can see, the older the child gets, the wider the gap becomes. Often a child at this stage might be 7 or 8 before they start considering a diagnosis. And it may well be that the child will be either diagnosed with autism or ADHD, which they may well have as well as FASD, or they might be misdiagnosed, or they may not be diagnosed at all. They may be considered the naughty children or the children with behavioural problems. Certainly the families that we've been working with where they have either fostered or adopted the children are often actually told that it's attachment disorder. So executive functioning problems it is the managing director of your brain. So the hot functioning issues may well be that the child has got poor impulse control, there's lack of insight into effect of the behaviour, poor learning from past mistakes. Cold executive functioning means the difficult sequencing or an inability to work independently. So it can have a huge impact on the child's ability to make friends, to actually understand emotions, to actually understand consequences, and to be able to engage in education in an appropriate way. I'm going to show you a little video by one of the mums that we're working with. Can I say that this is a shortened video and the whole video is actually available on YouTube, and I would really encourage people to have a look at it.
I think there's this kind of image that people are being hysterical about it. Come and spend some time in a house where you've got control of spectrum disorder, and I don't think you think that anymore. I think it's really difficult that there isn't more awareness about FASD and more acknowledgement of it. There was a study recently that found that it can affect up to 17% of children. So it's a huge, huge issue, and yet no one's heard of it. Much. It can feel really like a lonely place if no one else acknowledges or known about it. I just wanted him to be typical, and I was kind of not aware of how he wasn't really. There was quite a lot of flashing out, sometimes with staff and other children. It's just like this kind of volcano sometimes in the room. One of the sort of red flags quite early on as well was when he started to say his first words. He started to say about 10 words maybe, albeit very indistinctly. I remember he just stopped saying those first words. And I remember being really concerned about that. And I would try so hard to get him to say those words again. And he just wouldn't. It was like they'd been wiped. You know, his behaviour was often not typical. And trying to sort of cover over that and you know, pretend everything was normal was starting to get really stressful. So yeah, we started looking into it. And when you first look at it, it's really scary. And you start to understand that your child has got permanent brain damage. That's really distressing, and there's a lot of grief involved in that. He is, in so many ways, an amazing little boy. He's such a survivor. It's really loving and affectionate and a beautiful little boy. But once you see the effect, it drives me absolutely insane to see people saying, "Oh, just he'll drink fine," and that's something we really need to get through and get across to people. And once you understand the extent of the damage that it can do and the real consequences for the child and the family, you just think this is just ridiculous that people understand this. I think this is kind of.
So in relation to raising awareness, we said, as I said earlier on, we did a 10-week campaign around Go Alcohol Free, no risk of FASD. We had this independently evaluated by an external company, and we had some very, very positive feedback in relation to it. I think the thing that we were most pleased about is that people had an increased awareness of the impact of alcohol. Prior to the campaign, they were able to say that there was low birth weight or risk of miscarriage, but after the campaign they recognised that there was potential of learning disabilities, of long-term effects on physical health, and that actually it was a lifelong illness. So we were really, really pleased about that. The second phase of this campaign has been launched on the 7th of October, and it's much more around healthy pregnancies and looking at healthy pregnancy as a whole. A lot of it will be, it's all on mobile, it's all on digital, so it is very much a digital campaign. So I think at this point we were going to stop for any questions that had come through in relation to FASD. Okay.
Okay, so it doesn't look like any of you have typed any questions at the moment, so please reflect on what Roisin said and send us in some more questions, and we'll gather those and we'll make sure that we address all the questions at the end. We're going to step back out now, and Allison's going to continue the slightly broader perspective.
I'm just going to very quickly go through this useful information. It's not a problem. It's absolutely fine, Wolf. It's not a problem. There is a variety of useful information here, which are all handouts that you can print off to either discuss with your colleagues, discuss with families that you might be working with. And at the very end is an extremely good podcast by Dr. Sarah Brown and Dr. Jennifer Shields, who both work in the Scottish services. And this podcast is very appropriate for anybody who's working with children. I'm going to pass you now back to Allison.
Thank you, Roisin. So for this next part of the final part of the presentation, I'm going to talk a bit about neonatal abstinence syndrome, engaging with dads, some direct work approaches, and amongst that also I'll be showing you a short video of some parents in recovery talking about their experience of having a brief intervention. There we go. So, neonatal abstinence syndrome. So what is it? So it's a group of withdrawal symptoms seen in newborn babies, and it's caused by a sudden withdrawal of some substances at birth. the effects are very similar to those experienced by an adult who suddenly stopped taking substances. So infants are at increased risk from mothers who have taken the following drugs during pregnancy. So heroin, methadone, Subutex, amphetamines, cocaine, codeine, benzodiazepines, LSD, and some antidepressant drugs. So how does it present? So signs and symptoms of NAS can be different for every baby, and they can also range in severity from mild to severe. And most happen within 72 hours of birth. Some may happen immediately after birth, and in some cases not until a few weeks after birth. And that's why it's really important that you get a really detailed history of what substances a mother has been taking during her pregnancy. So symptoms can last between 1 week and 6 months after birth, and babies with NAS may need more specialised medical care and perhaps medical intervention to help manage some of the symptoms. So a key message here is, do remember that most babies with NAS who get treatment do get better within 5 to 30 days once they've withdrawn from the substance. So how does it present? So it presents with body shakes, tremors, overactive reflexes, which will present as muscle twitching, excessive crying. There's a very particular high-pitched cry in some babies with NAS, and once you've heard it, you'll immediately recognise it. Some babies with NAS present with poor feeding, their sucking reflex is poor, and as a result, they have slow or poor weight gain. They can have breathing problems, including fast breathing. They suffer from sweating, fevers, blotchy skin, trouble sleeping, and some babies can yawn a lot. They may also have diarrhea or vomiting, stuffy noses or sneezing. Right, so now I'm going to move on to engaging with DAS and why it's really important during those important 1,000 days. Father's attitudes and behaviours are really important and can impact significantly on mothers and babies during pregnancy and birth. And it's important that we remember that in actuality, most fathers are around during those important first 2 years of a child's life. We know that mothers rely very heavily on their partners, and they will rely on them, above any other caregivers in their circle. Mothers feel more confident and more capable, particularly about breastfeeding, when their partner is supportive. And we know that sensitive and supportive father involvement following the birth does relate very significantly to a range of positive outcomes for babies and toddlers. The influence of fathers on language development is equal to that of mothers. So the role that dads have in ensuring that babies and toddlers have the best environment in which to flourish is crucial. So key learning point, disengaged father interactions as early as the 3rd month of life have been found to predict behaviour problems in children when they are older. So it's really, really significant and important that we do engage with dads during this important time. I'm going to talk a bit about direct interventions, so some social work interventions. So social work interventions during this period is mainly focused on supporting and maintaining parents and dads or other partners to engage with substance use services. It's focused on ensuring that parents, mums and dads, have supportive and positive parenting skills and strategies. And also social workers are really significant in identifying what the protective factors are for babies and toddlers during that important time, especially identifying who in the support network can model good parenting and provide some much needed practical and emotional support to parents during this this really critical period. And these measures, can have a positive impact on reducing parental stress and in promoting the best environment for a child to develop and flourish. So, looking at some of these interventions, I'm going to talk a bit about brief interventions. So many social workers may be very familiar with brief interventions and may be trained in delivering themselves. So brief intervention uses motivational interviewing techniques to facilitate behaviour change. And they use MI along with the core skills of asking open questions, giving positive affirmation, effective use of reflection and summary. Brief interventions are time limited and they're very purposeful. And in pregnant women, brief interventions have been shown to modestly improve rates of alcohol abstinence. But I'm now going to show you a brief video of two parents who have received brief interventions talking about how it felt.
With IFSS, when my worker come out to me, we done a jigsaw, and the jigsaw was a little boy, right? And then all the different pieces was hunger, education, keeping him warm, keeping him tidy, all these pieces was there. And they'd be like, right, did your addiction affect his education? Did your addiction affect his hunger? Did it affect him keeping him warm? And, pouring that, instead of just talking about it.
And actually seeing it.
Yeah, and it that really worked for me, that did, yeah.
Like, IFSS look at things in depth. They actually take time. Like, to me, my IFSS worker took time to get to know me, rather than just what she had seen written down on the paper. Like, on paper, I was removed at birth, but then you meet me and...
That's it, everything sounds worse when it's written down on paper, doesn't it?
So do you think it really helps? But there's lots of people I talk to about social work, they say the issue is trust with a social worker. There's worries you can have children take it.
Massive trust. And even though I had the best outcome possible, baby came home and everything, like, me and my social worker didn't have a very easy ride in the beginning because I was scared. I'd never been involved with social services, not through my mum, not through anything else. I didn't know what was happening. So, like, because I didn't know in black and white that my child was coming home, they made me anxious. And, like, that didn't work for me because that was making me ill.
So having that goal-based approach, do you think that would be really effective?
Yeah, it was.
Yeah, because, like, it's your mindset to something then. Like when you've got social services involved, like, I suppose you've sort of got targets to achieve because you've got to jump through the hoops they put there. But when you're setting your own goal, like, you don't have to set something that's not realistic. You can set something as simple as, I want to go to a beach with my child. Yeah. You know what I mean? Like, and because you've set them, they're realistic.
Yeah, and then it makes your recovery more achievable.
Yeah, because there's not someone saying, you've got to do this. It's, we can do this. Like, they talk through it, so it's not, like, not even that you're on your own. Like, we can do this.
Yeah. Then, you'll be all on the same path then. So IFSS, I'm on the same path as the social worker. We all are looking at the goals that IFSS sets out for UNC, and we all know what I need to do and what will happen once you achieve.
Like, I think goals. If IFSS weren't involved in either of our cases, like, there'd be very little that the social worker would actually know about our drug use and our feelings, because, like, what marks a red flag to social services may not to IFSS, because they understand about the addiction and how it all, like, goes together.
I relapsed once 4 years old, and I went to Wakada, filled out the forms to get myself on the prescription, and on the back of the forms it says, what's your child's name? Are social services involved? If so, are they on the child protection register? Now, that's what scared me, and that's what made me stop there and walk away, right?
Yeah.
So if social services, and this is what we're doing now with NSE, we're going to try and change these forms and that to, that's the starting point. When a parent goes to a drug agency to get help, they need to grip them with both hands
and say, look, we won't punish you. Well done for reaching out for the help that you need.
Yeah.
But a lot of people have gone and asked for help
and
had their children removed, and then that's the starting point for them to spiral downwards, because you've basically taken their life away from them. Like, yeah, their life's already spiraling, but if you pull it early, like when you go and ask for help, like, they shouldn't be punished. They should be rewarded for asking for help, because it's a massive thing. Like, it really is. Like, I don't know, like, with a lot of cases, I think if IFSS workers weren't there, a lot of us would not even have our children, because I don't know, it's like they put our words into massive, like, what social workers understand, but put it across, like, from our point of view.
Well, what you don't know, you're scared of the unknown, aren't you? So
yeah, absolutely.
If the social workers don't know you, and they're not gonna, if they don't know, or if you've kicked your addiction, or you're trying to kick your addiction, and the social worker don't know about that, they're going to be like, they don't know if you've improved your lifestyle, so I'm not going to risk putting the child back with you. But with IFSS telling them they have improved their lifestyle,
like, look at this to this, like, like, say, can't get out of bed when his son is waking her, to gets him to school every day on time, dressed, clean, breakfast. Do you know what I mean? Like, it might not even be like look like a lot, but it is. Like, for you not to wake up and need a substance, like, that was my biggest thing about getting off everything, was I don't have to rely on anything to get out of bed. I just rely on myself. Like, from there to there, huge. No.
Yeah.
Yeah.
And I love my boy so much, I was willing to ask someone else to look after him. Well, because it killed me, like, not being able to do things with him, because I was ill. I felt so guilty.
Or having to take that before you could do something with it.
And then knowing that 20 quid I could have been taking him out for the day with. It's just a vicious circle, and you gotta use, because otherwise they're on the set, he's spewing, and they ain't entertaining themselves.
And then when you ask for help, you get A, judged, B, you get social services involved, C, you get your child removed for asking for help. So when someone wants to ask for help, they got no one to turn to, so they turn in on themselves and downwards.
So largely, I think what you're saying is social services need to let mothers know that, I know that you care and love about your children, and I know that in the future you're going to be capable to look after your children, but what our job should be is to get you there. Absolutely, to get you there, ready for when your child is born or when your child comes home, that you are capable to look after them.
But I think, I hope that you could hear from that there were some really important things about the relationship between the social worker and the parent receiving the brief intervention. There was something really important about being very goal-focused, and also there was also, it created a space for difficult conversations to happen, but difficult conversations to happen in a respectful way. Right, so I'm going to talk a little bit more about motivational interviewing. So basically, motivational interviewing at its simplest is just, it's a helping conversation, and it's a helping conversation about behaviour change. And again, it's one in which social workers will be familiar and regularly engage. So MI, motivational interviewing, is used by suitably trained social workers to guide parents and carers in making positive behaviour change, and it's effective either pre or post birth. And again, motivational interviewing is all about finding what are the key motivators and drivers for parents to make positive behaviour change. And we know that, you know, one of the key motivating factors for parents is pregnancy and childbirth. So it's about harnessing that really key moment, that key opportunity for change. And in the social worker parent relationship, this is achieved through arranging, so it's a purposeful conversation so that the parent effectively talks themselves into change by being aware of their ambivalence and resolving this ambivalence and finding their own important motivations and reasons for making that change. And in this instance, it's pregnancy and childbirth. And as we could, I hope you could hear from the video that you just heard, empathy and compassion and authentic collaboration were sort of key ingredients in the relationship between the social worker and the mums in the previous video. And again, thinking about you know, a preventative approach, the earlier that positive behaviour change happens, then the better the long-term outcomes for babies and toddlers. So some of you may be aware of Grow Brain. So Grow Brain is an intervention that, again, is targeted in these key first 1,000 days in a child's life. And it's designed to increase the opportunities for optimum health and brain development across the lifespan. It's a parenting course which can be undertaken pre or postnatally, and it can be delivered either to a single parent, to mums and dads, or in a group. The tools and resources that are used in Grow Brain are really visual, they're interactive, and this is really important. It's really inclusive and it's suitable for a variety of different learning styles. And the course can be delivered by anyone. Social workers can be trained and deliver it, but it's also delivered by health visitors and by family support workers. So I'm just going to end on some important key messages. So I think Roisin has echoed this as well. It's really important not to be judgmental. Women really don't use alcohol or other substances in pregnancy because they want to harm their baby. They may not know they're pregnant. They may not know the most up-to-date and current advice. They may be under pressure from others. They may be coping with difficult life experiences. And it may be at this point in time that the alcohol or other substances are actually helping them cope with some of these really difficult experiences and stresses. And I think Roisin again talked about the importance of a multi-agency integrated approach. Do ask questions at the earliest possibility about parents' alcohol and substance use. This has to be an integral part of your assessment. You have to record this. And again, it's really important if at a later stage diagnosis of FASD is being considered, that someone has documented this really important information somewhere. Again, we've said that fathers play a really, really important role. So engage with them, make sure that they are part of your intervention, and look for those protective and resilience factors. You know, they are there and they're going to be really important and shouldn't be overlooked. We look for risks, but we must look for protective factors too. Empathy, respect is incredibly important, helps reduce some of the fear and the stigma. And we could hear from the video that approaching with, you know, empathy and respect actually led to more disclosure. Social workers are really, really busy. So remember that helping conversations can happen in a really short period of time by really skilled practitioners. Oh, sorry, we seem to. And that's my last slide. So do we have any questions at this stage?
Yeah, we have a comment and a couple of questions,
okay.
And we've got just a little bit of time. So we've got another sort of 5 or 6 minutes before I have to wrap it up. So we had a comment from Helen, which was not a question, but she just said, thank you, Roisin. It was really interesting.
Okay, thank you very much, Helen.
There's a couple of questions about the multi-agency stuff, but we'll come back to that. This other question, which I'm not sure which the two of you want to answer particularly, it says, what can adoptive parents do if they believe a child has FSAD, but a birth mother has told a social worker that she didn't drink alcohol during the pregnancy? As a mother who's known to take drugs during pregnancy and has a history of drug and alcohol use, but is suggesting that they haven't taken any alcohol during pregnancy.
It can be very difficult. I absolutely appreciate that. I think the first thing is also obviously go through your GP in relation to being referred into whatever your local services are, and that's sometimes to your local paediatricians and your community paediatrician teams. There is a way of getting a diagnosis. So sometimes what they may well do is some genetic testing and actually rule everything else out, and therefore the only other diagnosis it could be was FASD. That isn't, I will be honest, readily available everywhere. You will have to speak to your local GPs. They may well have to discuss that with their local CCGs and your local treatment system. But that is one way of getting a diagnosis without there being knowledge of alcohol in pregnancy. To add anything to that?
No, I don't think so.
Okay, and then a question perhaps more specifically for you, Alison, but maybe Roisin, you know of these examples as well. So do we know anywhere where there are social workers and midwives working together in a team?
We do, yes. So I think in the introduction, Wolf said that my previous practice experience was in an integrated family support service. So these are specialist teams in Wales that comprise of consultant social workers and intervention specialists. And the intervention specialists in those teams are primarily nurses. So some of them will have a background in mental health nursing, and some of those will have a background in substance misuse, specialist substance misuse services, but also some of them were health visitors and community nurses. So the Integrated Family Support Service is an example of an integrated model in Wales.
And there are examples of ISS in England as well, aren't there, in Ipswich and other places?
Yes, yes.
There is actually a report coming out from the Department of Health in about 6 weeks' time, which has been written by a gentleman called Andrew Trayton. He was actually seconded from Public Health England last year, and what he was requested to do was to travel across England and actually find out what services were available specifically in relation to FASD. And we've seen an original draft of the paper that he's going to be bringing out, and what that does also look at is areas where there's good practice, but also areas where there are integrated teams. Certainly look out for that. That should be out by the end of November.
But I just wanted to add that in Wales, it's actually built into legislation that every authority in Wales has to have an integrated IFST.
And I suppose connected to this, we have a question that's wanting to know whether or not multidisciplinary peri and postnatal services can help in the situations you've described.
I think certainly, absolutely, certainly, and I think it goes beyond that. Certainly, if you're looking at diagnosing and working with children, educational psychologists have a very big part to play. Often these children will first be picked up by speech therapy because they've got delayed speech language issues, so occupational therapy is another team. Within Scotland, it's a very different way of working in Scotland. The health service is very different, and they kind of work in hubs. They've actually had, in the last 3 months, extensive training by a Canadian team where they've come over and trained 150 clinicians around assessment in relation to FASD, which includes social workers, paediatricians, occupational therapists, speech therapists, speech and language therapists, educational psychologists, to ensure that actually that any individuals who are coming into an assessment get a very holistic assessment to meet their needs.
And of course in Wales, it's the primary care hub model that we're moving towards, and it's really important because often we'll all have a piece of the jigsaw, but working in a multi-agency integrated way means that we bring all of these pieces of the jigsaw together.
And it's absolutely necessary, not just for children with FASD, but any child on the neurodevelopment pathway.
So finally, I've heard two very clear messages, one about there's no safe levels of alcohol, obviously, and one from you, Alison, about social workers have a really active role in these conversations. I wonder if either of you have got one kind of final message that you might want to say to the audience, or so one thing that you might want them to really hear. Those are the two things that I've heard.
Okay. I would say, well, maybe it's a couple of things. Approach every contact with compassion, empathy, and in a non-judgmental manner.
I think from my point of view is to consider maybe the children and the families that you're currently working with, thinking about some of the information that we've given you specifically around FASD, and potentially think about whether some of those children actually either haven't had a formal diagnosis or have been misdiagnosed, and then start having those conversations to think about how we can support them appropriately and meet their needs.
Okay, well, I want to thank both of you for what's been a really interesting conversation on a very specific area of alcohol and drug work for social workers. I'd like to remind everyone listening that there's a lot more broader resources about the relationship between alcohol and other drugs and social work, which can be accessed through the BASWA site, and in particular that of the special interest group. We have one more webinar in the BASWA series today as part of the digital conference, and you can sign up for that to listen to that later or catch it within the 48-hour window. And just to say thank you very much for listening, and thank you very much for our speakers, and to Stephanie for all the OT stuff. Thank you very much indeed.
Thank you.
Thank you.